Hi, I'm Rick Feins, Professor of Surgery, University of North Carolina.
Hi, I'm James Fann, Professor of Cardiothoracic Surgery, Stanford University.
George Hicks, Chief of Cardiac Surgery, University of Rochester Medical Center.
We're here this afternoon to discuss the dilemma of whether simulation-based training can replace the old paradigm of see one, do one, teach one. So let's start with sort of the question of what are the problems with see one, do one, teach one? We've trained an awful lot of terrific surgeons through the years. Why can't we keep doing that?
Well, first of all, it doesn't exist anymore, so we can start with that premise. The concept of a resident, almost independent of level, seeing an operation, doing it, and then teaching it is historic benefit only. The pressures of everyday surgery, the pressures of patient safety, of governmental review just don't allow that.
Yeah, the way I see the problem is that we're still a open surgical-based specialty. The changes in general surgery training in terms of more laparoscopic, endoscopic surgery has shifted a lot of the emphasis to the ability of doing things less invasively and not open surgical. And so effectively what we have is we have residents that historically have had great open surgical experience come to us in cardiothoracic surgery training, and we're starting to have to just sort of change the conventional approach to general surgical training. And coupled to the fact that Dr. Hicks talked about some of the public review of how we train residents, that's changed somewhat, and that's in a sense forcing us to think of alternative methods of training our residents.
So at the present time, if you don't have see one, do one, teach one, how are you training your residents?
Well, of course it depends on the level of the resident. Since the paradigms have changed from the traditional approach of 2 years or 3 years after general surgery to a more innovative approach of the integrated 6 programs, we take residents from their medical school and begin to develop their technical skills. The problem is in the operating room, we now have residents without the skills they need. And that not only creates no confidence in the attending surgeon trying to allow them to operate, but it also doesn't help the resident in trying to learn operations at that level. That's why simulation has become so important.
You know, what's interesting, Rick, is a number of years ago when we started thinking about training our residents, it was in fact in the transition between the traditional way of doing open surgical training and into laparoscopic training, what we found that we really needed to figure out a way to get residents a method of practice. So the simulation approach, which at the time we didn't call it as such, we just thought it was a great way to figure out how to get the resident to practice procedures outside of the operating room. And so the original need was strictly it was based on what we perceived to be a component of training that, again, is manifested in all other domains of expertise and expert performance. So, and we found that that was absent in our domain of surgery. So the simulation component in learning, getting our residents to learn how to do surgical procedures required that we develop a method for them to practice outside of the operating room.
So what do you now envision the role of simulation-based training should be? How is it going to be used to meet some of the challenges that we have with our present-day operating room and with our present-day skill level of our residents?
Well, if we've learned anything over the last 8 or 9 years in terms of our experiences, not only with boot camp but other aspects of simulation, we know now that we weren't that great a teacher 10 years ago. But we know that in the environment of simulation, we can be a better teacher under less pressure and have a rapport with the learner, the resident, so that they actually learn and can improve their techniques over time. The consequence of that is that we become comfortable with them, confident in their skills, and that translates to the operating room.
So how would you, and then Jim, I'll ask you the same, how would you envision a curriculum, say a 6-year curriculum? How much of it would be simulation? Where would simulation fit in? And what would simulation try to accomplish during that 6 years?
Well, that's a loaded question because we know the answer if we look at our what we accomplish nationally. But simulation allows for the early learner to begin to master skills in a uncontentious way. And they can practice them and they can be trained to do what's right. And that is in the early years. The seasoned learner will not do as well in that environment. They're much more attuned to the operating room and in most instances should be capable of learning in complex cases. Where we think most of the advantage is in terms of recognition of adverse events and being able to react appropriately, quickly, and in a safe fashion to decrease complications.
Okay.
What I found in trying to figure out how we're going to structure the curriculum, what I found was that it's pretty much universally known that low fidelity simulators are very helpful in the early stages of training to learn the basic skills, some of the, for instance, basic anastomosis skills. And as the resident progresses, then it becomes more important to work with high fidelity simulators, tissue-based simulation, and simulation for crisis management. So the way we would structure such an approach, and I must say, we should ask you as well as to how, you set up the original curriculum for the AHRQ grant. And so the way we've structured it was to use low fidelity simulators, task trainers, and then to progressively increase the use of high fidelity simulators during the latter years of their training. And eventually, they won't need to be in the simulation lab at all. And that's really the key, is that we're providing tools for them to get to a certain level so they won't need us anymore in the laboratory, but in fact, they will be able to optimize their experience in the operating room. And so I'm going to ask you, is your original, the impetus for the development and submission of the grant was to better define the question. And what were you thinking at the beginning of all this in terms of how you wanted to structure the grant, and how did you make a compelling argument?
Well, just so the audience knows, we've just completed a 3-year grant among 8 centers in the United States where the data shows very conclusively that the residents will get much better in their technical ability with repetition. The grant itself was to maximize simulation-based training by using some of the basic principles that have been involved with achieving mastery, and that is deliberate practice of a task over and over again with coaching, being able to move someone out of their comfort level, those kinds of things that allow everyone else to become masters. And the second is to take a complex task and break it down into smaller tasks that can be learned and then recombined. And as I said, the grant as being presented at this meeting has shown clearly that that's the case. But I think both of you, being very strong participants in this grant, realize even more now that there are challenges towards the introduction of this. It's been given to the Thoracic Surgical Directors Association, but it's only going to be as good as the adoption allows. So why don't you just talk a little bit about some of the challenges involved with getting this paradigm shift and how you think they might be ameliorated?
Well, the challenges are pretty clear. One is time, in some degrees money, but in most of the aspects, resident involvement and dedication by the faculty. If you have a dedicated faculty member or faculty that will teach in a simulation environment, then you have 90% of what you need, regardless of the type of simulator they use, low fidelity, high fidelity. And it takes that type of commitment to be part of that. And it's only as good also as the residents' enthusiasm and willingness to work at improving their skills. Otherwise, it doesn't work.
What's interesting about the way the curriculum is set up is that it's fairly regimented and it's very well defined in terms of the activities, the various tasks, and the progression of the tasks during that 4 to 7 week period of the modules. And what we found that was very difficult was to try to balance the clinical requirements for the residents, the clinical opportunities versus the opportunities in the simulation laboratory. I'm of the opinion that we should never take somebody out of the operating room and put them in a simulation environment because of the opportunities are so great within the operating room. And we do have service needs that are not that flexible in terms of the clinical activities in the operating room. So that really, I think, is the basis for the challenges is that, again, what Dr. Hicks talked about is the fact that there's time issues and there's responsibility issues. So what I envision is a much more flexible approach to simulation, is to identify the needs of the particular resident and be able to customize, using the curriculum, customize the way we would take care of some of the deficiencies and be able to optimize their experience in the operating room. And this is contrary to some of the approaches of what some of the other investigators and some of the other simulation experts have advocated, which is to have a defined period of simulation during the rotation at a given time.
Right, and I think that's sort of where I'm coming from. I'm of the opinion that a resident should achieve a certain level of competency and a certain skill level before they enter the clinical arena, even for the first time. And we have shown that simulation can do that. To see a resident struggling or learning in the clinical environment with things that could be much better taught in the simulation environment, to me doesn't seem quite right. I think all of you, both of you will agree that we learned a lot about teaching, both in the operating room and out of the operating room during this grant. We've learned a lot about teaching during the boot camp now in its 9th year, where the residents have come from all over the country. And one of the things we've learned is that it's a lot of fun. I mean, it's a lot of fun to be teaching in an environment without the pressures and to be able to stop and correct and let a resident make a mistake, and all of those advantages that they have. But we have tremendous challenges with sort of workforce issues of getting, as you mentioned, getting people out of the clinical arena where they have certain duties, workforce duties to perform, and into a purely educational environment.
We also have responsibilities in terms of patient safety too. And if we believe that we can help residents be safer in the operating room, learn faster, and parenthetically improve patient outcome, then we really have to continue keeping our foot on the accelerator of this technology. It is a powerful tool, and I think in reasonable proportions provides the resident with a comfortable environment not only to learn but to transition to the operating room, where obviously eventually they have to prosper. And we've all learned that over the years.
What I find to be extremely helpful are the crisis management modules. Historically, the training in crisis management has been limited by the ability or the time that's required for the educator to develop these protocols. And through the efforts that you spearheaded through the grant is that we've developed these modules for crisis management so that they could be universally adopted. So when we talk about formalized training and simulation, which is, again, the part that I think is critical to get everybody together, is to work through the crisis management, such as intraoperative aortic dissection, massive air embolism. There's no, that's not something that, in my mind, is flexible with respect to simulation training. Technical skills, we could work on that, and we could work on that, after after the clinical responsibilities are completed, we could work on that. Crisis management, on the other hand, requires a team approach and requires a formalized approach. And that's something, as indicated by all our discussions, is that you could not teach rare events in the operating room because they're rare events. Not every resident experience those, or will have the opportunity to experience those, and the first time they do it, maybe the time that they're alone in the operating room with a surgical assistant and having to deal with it for the very first time. And that, I think, is a patient safety issue.
So all three of us have been members of the American Board of Thoracic Surgery. You presently, Jim, are presently a member of the American Board of Thoracic Surgery. What role do you think simulation is going to play in the certification of our graduates?
Well, I'll try to moderate that a little bit by saying that right now there is a simulation requirement for the American Board of Thoracic Surgery, and it's 20 hours of simulation time and over the training period. And what I find that to be incredibly important is that we have taken the steps to introduce simulation into the training. And I think in terms of the mechanics of setting up the simulation, we've just helped them establish that. In terms of identifying the need for simulation, I think we've done that. So the fact that the American Board of Thoracic Surgery has adopted the concept, although not the specifics of it, I think we're moving in the right direction. Eventually, there will be competence and potentially evaluation that we would do as program directors and associate program directors to be able to figure out how we could document the progress and through the milestones, ACGME milestones, that will be incorporated within, I believe at some point, the requirements for the American Board of Thoracic Surgery.
For the examination. Jeff?
I just think it eventually will have more importance, but it will never be an exam that they will pass-fail for their certification review.
What about adverse events?
Adverse events, well, in fact, that's something that we do test them on orally in many regards. But in terms of actually physically reacting to adverse events, I don't know that that's going to be part of the examination. I do know that the pressing need will be, prior to that, is evaluation of the I-6 residents at some point in the mid part or at some point in their training to be sure that they're accumulating the skills that they need to move on. And we would all feel very badly if they spent 3 years and still didn't have the skills they needed for the senior years.
Yeah, so my question to you is, Rick, as the former chair of the American Board of Thoracic Surgery, and having instituted at least the format for the Integrated 6 program, what's your opinion of simulation-based learning in the residency I-6 training paradigm, and also potentially as a requirement?
Well, I think it's going to have a very big role. There are, I think in many respects, it's a much better way to teach than what we're presently doing. It takes a lot of the work out of teaching in the operating room by having skills instilled before they get to the operating room. And in terms of certification, I think we're really going to be able to say to the public that our graduates can handle certain events, should they occur. We could use simulation to demonstrate that they have had some experience and can indeed handle those, at least in a simulation environment. So I want to thank you both very much for sharing your views. I think it's clear we have a very, very powerful tool now, our profession, probably some of the most advanced simulations, and with this curriculum, education around, and it's really up to us to see how best to use it.
Just so
thank
that
you.
Viewers understand, I'm surrounded by two of the most innovative and disciplined people I know. And much like the Wright brothers, this probably wouldn't happen without both of them together. Rick's innovative and totally courageous in terms of pushing things forward. And Jim has an incredible academic discipline which went very far to make this more scientific than just passionate. It's been a great experience.
Thank you very much.
Thank you very much.
Thank you.